Good evening, and welcome to Session 7 on Safety Net Programs of the TMC Health Policy Institute's Health Policy course. Tonight, we're going to focus on safety net programs and safety net issues, and the moderator is Abida Solomon, an associate professor at the College of Nursing, Prairie View A&M University, and I'll turn it over to her right now.
Thank you, sir. Thank you, Dr. Linda, for the warm introduction. And welcome to all of you. I know the weather is not in our favor today, but I'm glad you could make it. I look forward to a fun and engaging discussion session. And with me today, I have a distinguished panel of health professionals from diverse backgrounds and expertise. They're going to help me run this discussion, and I'm going to ask each one of them to introduce themselves. But before I do that, I would like to make a quick correction. And one of my panelists, Mr. Kevin Nix, couldn't make it, but he was gracious enough to send a representative, Miss Lindsay Lanigan, is going to step in his shoes, and I am so pleased she was able to make it. So you are not dreaming. I still have Mr. Kevin Nix on your program, and just like I said, I didn't want to disrupt the program, so I thought I would just inform you in person of this minor change. With that said, I am going to turn to the ladies first to introduce themselves, and we would start with Ms. Lanigan.
Sure. Hi, I am Lindsay Lanigan. My job is actually the Director of Government Affairs and Public Policy for Legacy Community Health. Legacy Community Health is a federally qualified health center, and I'm happy to go over what that is. Should I do that now?
Not yet.
Okay, not yet. We are the largest federally qualified health center in the state of Texas. So,
welcome.
Thank you. Thanks for braving the rain.
Ms. Russell?
My name is Saramma Russell. I'm a family nurse practitioner. I work for healthcare for the homeless Harris Health Systems, and I've been a family nurse practitioner for 14 years, and I love what I do, work with the homeless.
Mm-hmm. Welcome to the party. And now we turn to Dr. Bagley.
Okay, I'm Charles Bagley. I am a semi-retired part-time professor at the UT School of Public Health. And I'm co-director of the Center for Health Services Research there. This is one of my major research and teaching areas, safety net and healthcare safety net. And the other area that I do a lot of work in is in a particular disease area of neurological diseases and epilepsy specifically.
I am so excited to have Dr. Begley with us. As he mentioned, he's taught this content for several years at the UT School of Public Health, so I can't wait to hear him talk about it today. Okay, so a brief comment. We all know that the evidence is out there and is very clear that health insurance, people without health care insurance, have the most difficult time accessing care and services, and as a result are more likely not to receive preventive care and services for major health conditions. So, and we've been talking about these same issues for years. I don't know about you guys, but I'm beginning to get tired of talking about it without any solutions. We're still talking about it in 2019. That tells us that we are not doing the things we are supposed to do to resolve these issues. And they call that insanity. So I'm hoping that these discussions would help us come together and work out some meaningful solutions to address these issues so we stop talking about them for once. Okay, so without a universal health coverage for all Americans, what has happened is that the healthcare safety net programs have become default systems in providing care for millions of low-income and uninsured Americans. And we would talk about this more in detail in our discussion when I turn it to our panel. Before we even get to talking more about these programs, that has been a good resource and also filling in the gap in the absence of a universal health care. I'm going to run a couple of questions, poll you on that, and see how you do before we turn to the panel. So, if you all can, you see on the board the instructions to answering these questions. I'm going to go to the first question, probably give you about a minute or two to respond. And so those of you who cannot see, I can read it out. Since the passage of the ACA, the uninsured rate has consistently decreased across the state. True or false? Okay. I think we have the answer. And I wanted to know who said true. That, yes, sir, can you explain your answer to me?
With the exception of what's happened with some of the defunding and taking away and deconstruction of the ACA, we had seen progress in every state, even states that didn't expand Medicaid. However, in I think 2018 to 2019, with part of the deconstruction, we've seen some clawback.
That is correct. There has been some decreases in the number of people without insurance, especially significantly so in states that really expanded Medicaid. But it looks like the benefits that we had with the implementation of the ACA is beginning to reverse course, and it started reversing course in 2017. I need to hear from you. What happened in 2017 that you think may happen?
I just got a clarifying question.
Sure.
When you say uninsured versus insured, are you talking about, is that including Medicare and Medicaid? As
Yes.
insurance?
Yes, that includes that. I was just saying that we had some benefits, especially in states that expanded Medicaid. But in 2017, it reversed course. About 700,000 people lost access. So I was wondering what major policies were implemented in 2017 that led to that. Any suggestions? Yes, sir.
The court declared part of it illegal, as well as reduction in some of the subsidies.
Yes, that's correct. So we had the individual mandate repealed in 2017 as part of the tax bill that was passed by the Congress. And also they did not reauthorize the programs for the CHIP, Children's Health Insurance Programs, and also community health center programs. So this made a big difference in terms of the number of people getting access to health care. Good. All right, next question. Yes, sir.
Have the work for Medicaid programs taken effect yet? And has there been an effect that's been seen so far from states implementing those?
From the who?
Are you talking about work requirements for Medicaid
Yes.
programs in Kentucky?
Is that the only state?
No, there's several states that have done it. I think they're caught up in the court system right now. They implemented those
Yes.
fully?
Yes.
Chuck, do you know?
Well, I think they've been, like you say, I think some are in the courts and some have been implemented. And the record is, the reports are very mixed. At this point, at the total macro level, it has led to 7 additional states pursuing a Medicaid expansion under the Trump administration, what
Right.
nobody thought would happen. Okay, but these are all states that tend to be, red states, that the Trump administration's loosening of requirements and allowing states to do Medicaid expansions with work requirements on that newly eligible population has encouraged that. But it's all kinds of controversy about whether or not it's increasing or actually increasing or decreasing people, the number of people insured. Because it's decreased, it has the effect of increasing the uninsured by the people being kicked off of Medicaid because they can't meet a new requirement. It always happens. You put a new requirement on Medicaid, you're going to lose some people.
People, yeah.
But versus making it possible for people who couldn't before get on, but it's too soon to know what impact. But it is encouraging in the sense, the overall sense that Medicaid expansion is a big game in town right now. And there's a couple of states, and there's even a resolution to do a Medicaid expansion in Texas, working its way through the Texas legislature.
Did that answer your question?
Yes.
Okay, all right. Next question.
That was easy.
Okay. Am I seeing right? 100%? No,
Say yes.
86. 86, okay.
Okay.
We're still moving. Yes, so that's true. Several sources report this, that we spend more money on public programs and countries that claim to have universal health care compared to we known as a private system. Okay. Any questions on this?
I would just add that one of the reasons why that's true is because our healthcare system is so enormously bigger than any other country's healthcare system overall. I heard a statistic the other day that the U.S. healthcare system, which is now expenditures about $3.5 trillion a year, is larger than the entire economies of the UK, France, and closely approaching, surpassing Germany's entire economy. So it's big. This little problem that we're getting together and talking about every week is a fairly big issue.
All right. Your last question before we delve into the discussion. Question 3.
The divide between public spending and private spending on U.S. healthcare, how does that shake out?
I'm going to tell you in a couple of minutes.
Okay.
If you hold on to that.
Anticipation.
Okay. So select the true statement. Okay, I think this is it. Oh, okay, I still see it moving. So this information, this question came from the Kaiser Family Foundation, polling of Americans on Medicare for All, this January 2019. And all of that is true. 77% support A, and 75% support B, and 56% supports C. So there is a public move to have more access for Americans. Any questions on that? Yes, go ahead.
Go ahead.
No, get it.
No,
That's
please.
okay.
It's just interesting that Medicare expansion goes to 64. Medicare currently begins at 65, which also is typically thought of as retirement age. So people are living longer, but we're going to expand Medicare the opposite way, which is counter to what you would think of pushing Medicare expansion towards later life as people live longer.
So you see it as a negative, or what?
No, I just think it's. I don't understand why 50 to 64 would be the determining factor in expanding Medicare.
Currently 65, correct? So they're thinking to reduce the age, that would cover more people.
Who are
Less,
figuratively working.
who are not supposed to be, who are not 65. And not everybody retires at 65.
Sure. But again, that the reason that it was set there and the reason that it's always existed there is that it's historically the predetermined retirement age. And you would leave employment and leave your insurance, and then you would have a policy that covers you afterwards.
But yes, and like I said at the beginning, it hasn't resolved the problems with access. And so these are new kind of ideas that people are exploring in terms of increasing access of care, to care for many Americans. Yes, sir.
What the data seems to be showing is what the data seems to be showing is that Americans are beginning to think we should disengage healthcare financing from employment and moving more towards a financing system that is dealt with from funding through taxes and other fees.
Okay, that's a good. Dr. Begley, you have something to add?
Sorry, I just got dinged. Except that in the same survey, when asked whether people supported doing away with private health insurance, which is what the implications of an extreme Medicare for all single payer model is, they're not in favor of that.
Yeah.
So it's kind of inconsistent. Now, there are versions of Medicare for all. I mean, you've been seeing more in the news because it's become a political issue with the presidential race, that there in the Democratic Party, that there are different versions. Some would just Medicare for all is just providing a Medicare plan in the exchanges, a government plan in the government option, a public option in the exchanges, or providing a Medicare option in the private insurance market for the 50 to 64, versus others who want to go further and moving further toward a single payer system and eliminating the role of private health insurance companies, or at least reducing their scope quite a bit.
I guess because it's a more, I don't want to use the word extreme, but it's a larger difference. But why does the panel think that there's a higher level of support for A than for C? Well, I mean, what's specific or particular about 50 to 64 as a vulnerable population other than they're up against current eligibility?
Well, C is saying for everybody, right? for all Americans. And
More
then
large
A is saying this age group. That would be 50 to 64. So that's a big difference.
I'll also point out, just because I went through this recently, so my mother-in-law was 64 and had pre-existing conditions.
Right.
And I tried to purchase insurance for her, and that was around, and the cheapest plan I could possibly find was around $1,000 a month with a like $15,000 deductible. So I think what you're seeing is many Americans are faced with trying to insure themselves at that sort of marker before you're 65, and it's absolutely cost prohibitive. So I think that may be part of the impetus for just the cost in general.
Those rates would be different if she was 49.
I don't know her health status at 49,
Well, with the same,
but yes,
it would be
the
lower.
younger the person, the healthier they are. I mean, she had an aneurysm at, let's say, I think 52. So anything after an aneurysm, and you're going to exceed a higher rate of insurance. But also, yes, so the younger you are, the cheaper it is to insure you.
Yeah.
To your point, it's something that I recently read. There's a higher degree of job insecurity between 50 and 65.
That's a good point.
And then to combine that with the fact that the example that you gave, people are waiting to treat these conditions that just deteriorate, so the time that they get into the Medicare system, they're far costlier than if they dealt with it earlier. And those are the 2 points that I've heard used to validate that position.
Okay, thank you all for the contributions. All right, so we will move to our first question, discussion question today, and I will turn to Dr. Bagley to start us off. He's going to give us an overview of safety net programs, what their history objectives are, and then we move from there to the next.
Right, and answer the question, how big are they in comparison to the whole pie? How big is the safety net part of this? So I'm going to lay the foundation, the overview of all the policies and programs and funding, and then we've got specific presentations on specific programs. So start with a definition. That healthcare, that what we mean by safety net policies and programs are those policies and programs with a primary objective of preventing low-income populations and populations particularly vulnerable to poor health, disability, or injury from not receiving needed health care. Okay? So we have a target population and we have an objective for that target population. The target populations are, by their nature of being uninsured or vulnerable, tend to be populations that are disconnected from work, populations that are not able to afford insurance. They may be working but not have the income to acquire insurance on their own, or pay out of pocket for services at the point of service. These include, in general, and this is the whole long list of target populations for all of our safety net programs. We start with the elderly, and this goes back, to the creation of Medicare when the elderly people over 65 was the highest uninsured population in America back in the 60s. So it was related to retirement. And we created the Medicare program, and now they're the highest insured population in the country. So the elderly, uninsured and underinsured low income is another target population of our safety net programs. Mentally or physically disabled populations targeted by our safety net programs. Pregnant women, women of reproductive age are targeted by our programs. Children, individuals at risk of or with infectious diseases. There's a public health argument as well as a need argument for that population being a target. Women with breast cancer. And many of you know the interesting thing about women with breast cancer being a vulnerable population is women with lung cancer, women with other diseases, chronic diseases, Breast cancer is one of many, and it's probably not the most severe in terms of mortality, but politically, women with breast cancer got Medicaid coverage back in the 2000s, and it was purely the political effort of the cancer community and the women's health community getting together and making it happen. All right, and people with kidney failure are a targeted population of our safety net programs. Foster children, children living in our public foster care system programs, and low-income parents, okay, are targeted. Providers in our safety net programs range the types of care range across the entire continuum of care. Some of our safety net programs are focused on preventive, acute, chronic, rehabilitative, behavioral health, dental, palliative care services, but all of them have in common that they are funded to provide free or discounted at point of service care in a consumer-friendly way that recognizes the unique characteristics and access barriers of the population that they're serving. All right? The providers in our healthcare system who are safety net providers, again, very comprehensive set of federal, state, and local government, public hospitals and clinic systems, private, for-profit and non-profit, medical and social service providers. All kinds of providers participate and are part of our safety net system. And then the funding for our safety net system comes from all kinds of sources. Public and private insurance subsidies is the major one. Is that we have the government subsidizes us to pay the premiums, subsidize our premiums to obtain insurance, but also provides direct payments to providers and individuals and insurers. All right, so that's the overview of the basic framework. Now, the basic programs are, at the national level, Medicare, Medicaid CHIP, Fqhcs, the Fqhc program, which we're going to hear specifics on tonight. The health insurance exchanges are the new kid on the block. The VA, Veterans Administration, and the Indian Health Service. Okay, that's it at the federal level in terms of healthcare. Now, I didn't mention any of the public health kinds of things because we are focused on healthcare as a focus, but a lot of public health dollars that come from the federal government do find their way into healthcare services. But these are the main ones at the national level, national and state level, because some of these programs like Medicaid and CHIP are federal-state joint programs. At the local level, we have the two big ones are our hospital community benefits programs and our county indigent care programs. Okay, so let's look at some of the relative magnitude of these. The big ticket item is Medicare, established in '65, targets 65 years of age and older population. Eligibility requires a person to have paid Social Security taxes for 10 years or more, to get free Medicare coverage. You can still get Medicare. But you have to pay a partial premium for it if you work less than 10 years, paid less than 10 years of Social Security taxes. And then in 1972, the Supplemental Security, the disability population and the kidney disease population, and then in 2001, Lou Gehrig's disease was added. So. Okay, and then these are the four big parts of Medicare, A, B, C, D. I'm not going to go into the detail here, but that's Medicare, primarily people over 65, which, by the way, the uninsured population of people over 65 in the United States is about 4%. So it picks up most everybody. Yeah.
Why would there be like
Anybody?
why would there be a non-zero?
Well,
Yeah.
it's because it's voluntary.
So they choose not to.
Yeah. Some people have a high enough income that they really don't need any kind of insurance
so it's
coverage.
just
They
like
pay out of
administrative
pocket
work.
when they, yeah. But you can qualify for Medicare even if you are wealthy, because it's not income-based, it's age-based. And you pay in your Social Security, you qualify. Question?
So the Medicare Part B, I mean, you do get a reduction from your Social Security, so it's not free. I mean, they're actually charging every month that they take a certain amount out of your Social Security from that. So it's not really free. You're still
Absolutely
paying
not.
it,
No.
you know.
A is, there's no premium for A if you've paid in your Social Security. There's a premium for B, which is your physician services and lab and x-ray. And then Part D, which is your medications. And there's a premium for Part D as well. However, most people who work their whole lives and for an employer that provided good health insurance benefits, often in their retirement, they qualify for Medicare, and their employer often as a retirement benefit provides supplemental Medicare payments that covers the premium for Part B and D. And it also covers the significant deductible and co-insurance that are part of A, B, and D. What's that?
If you're with a nonprofit.
If you're, forget it.
Yes.
Yeah, no. But you have to go out and purchase it. You can purchase supplemental payments, okay? And it's a huge program. I mean, it's 60 million people, about 15% of the population. And the problem is it's growing. It's expected to be 80 million people by 2030 because all of us gray hairs are there's a lot of us. World War II baby boom generation getting over 65, and the payment for Medicare in 2017 was $702 billion, which represents 20% of the entire total healthcare spending bill for the United States, this one program. Yeah.
I've heard opinion over when discussing with a manager of an insurance company after a few glasses of wine, that the Medicare indirectly contributed to overall inflation of healthcare costs in the United States. Can that be true? The way it was when it was conceived, it was a really minority of the population, but then.
Yeah, perhaps. I mean, because of such a huge program, and because for many, many years, and it was and still is, the payment mechanisms are primarily fee-for-service, and are adjusted upward with costs, and so and contribute more and more to have contributed to inflation. Now, I will say that under the Affordable Care Act, Medicare inflation has been based on an algorithm. Every year they take the medical care price inflation rate and they add a couple percentage points to it. It's an algorithm that Congress had trouble passing every year that increased Medicare payment rates. Under the Affordable Care Act, the algorithm was adjusted downwards. So if you look at Medicare expenditure increases since 2010 to the current time, they're much lower than they were from 2000 to 2010. So we've slowed things down a little bit in terms of Medicare inflation, but it's still an extremely expensive program. All right, Medicaid. Also 1965, but the target is low income, uninsured children, parents, pregnant women, women of reproductive age, individuals with disabilities, and low income 65 and older. If you are poor enough and getting Medicare, you can get onto Medicaid for your premiums and your deductibles and copays. Eligibility is determined, since it's a means tested, it's determined by income, assets, and family criteria. And this is the single largest insurance program in the United States in terms of people. It covers more than Medicaid. It covers 73 million people. which is almost 20% of the population. And in Texas, I think Medicaid covers 40% of all kids, and over 50% of all births are paid for through Medicaid. And the cost, $592 billion in 2017. All right, so these are the two big ticket. Oh, the third, another big ticket is CHIP, Children's Health Insurance Program, passed in 1997, basically extends Medicaid to near poor children. It increased income eligibility up to 250% of the federal poverty level, and in 2017 covered 46 million children nationwide and cost $15 billion. Okay, so if I add up these three programs, I get $1.3 trillion a year. And you ask, how big is the safety net compared to the $3.5 trillion healthcare industry, healthcare bill? This is getting close, and these are the big three. The others I don't have budget figures for you. Yeah, I do. Let's see. I do have for FQHC, the FQHC program, created by amendment to Medicare Act in 1991. The objective was to improve the health of the nation's underserved communities. Okay, this was a policy where the way we addressed access was not by insuring people, but by paying providers to set up their clinics in low-income neighborhoods and provide vulnerable populations in those neighborhoods comprehensive, culturally competent, high-quality primary health care services. And that program that Lindsay's going to talk about, Legacy being the biggest FQHC in the state, costs $5.1 billion a year. And serves and funds about 1,250 centers around the whole country, and 8,000 sites that these centers operate. So you add the FQHC, the Medicaid CHIP, and the Medicare, you get the $1.3 trillion, which is getting close to half of the entire healthcare bill. Are this patchwork set of programs that we have created in our government policies to complement the private health insurance system that we have had. So no, we do not have a universal single-payer system by any means. It's a very pluralistic, complicated, but the public part of it, the safety net part of it, is huge.
I was just going to point out that the $5.1 billion actually saves $24 billion for the entire healthcare system in the state.
Saves $24 billion. Okay.
So we save on average around $1,500 per person in the United States. So sure.
The Medicaid, if I remember correctly, FQs get paid an adjustment on the Medicaid rate above. Is that included in the 5.1, or is that included in the 40 or in the 15 billion?
5.1 is the HRSA payment to FQHCs. So the additional payment that they get from the Medicaid reimbursement formula that they get would be picked up in the Medicaid bill.
In the Medicaid number. Okay,
Yep.
thanks.
The average cost for treating a patient with the Canadian healthcare system is around $6,000 a year, and with Medicaid or Medicare, the average is about $11,000 a year. What do you think contributes to those price or cost differences?
You want to go now, Lindsay, or you want to go later as a part of?
No,
Why don't we wait?
I actually think you answer that question. I mean, from a global sense.
Yeah. Well, from the global sense, they're providing comprehensive primary care.
Are you talking about in an FQHC setting, or are you talking about just as a patient in the United States versus? Yeah, exactly. So I think she's talking about from a global perspective.
FQHC cost per patient are below what it is, below the general expenditure cost per patient in the U.S. Yes.
Yeah. So what's contributing to make it more expensive?
Why are they able to do it for less cost?
Are you talking about specifically in the FQHC setting?
No.
Okay. Okay.
Probably less duplication. I don't know. I can only speculate. Less duplication because these are people who are regular users of a single provider because they had to have barriers to access to other providers. There also probably is less duplication of care. There's probably less access to specialized services because the Fqhc budgets that they get does not cover specialty care. And that's one of the challenges that you guys have is when you find patients with chronic disease and needing specialty care is linking up to specialty care providers and getting them access.
Sure. I think her question was more what makes healthcare in the United States so much more expensive than in other countries.
Oh.
Not in an Fqhc setting specifically.
In general.
But in general, right. So I think the cost of drugs is
If it's
significantly
a more
higher.
competitive market, because you have private players, you would think it would be less expensive.
Right.
Intuitively.
Right, and other countries have universal health care, so we're looking at a completely different system in general. This is like,
Why the system is more expensive.
But I think it's the focus in the less expensive system is mostly focusing on preventive measures, preventive care. But in where you see the cost go up is when we wait and everything is centered on treatment. And especially when we don't have access to preventive care, situations get complex and deteriorate, and it costs more to rescue those kind of situations and treat patients.
So in Medicare, Medicaid specifically, do you think there needs to be more of a focus on preventative care then?
Yes.
I think any provider would probably tell you.
Yeah.
I mean, I used to work in cancer care, and they always said that 70% of cancers are completely preventable by just being a healthier individual in life. And so, there's lots of preventative things that we as the United States could do to help folks.
For example, if you do your preventive care, the women, we do our mammograms
screening.
and self-breast exams, you detect a lump, usually it's caught early, so you get treatment and at a lesser cost than if you did not engage in these preventive behaviors and it spreads to other organs and other things, then it becomes more expensive. Is that?
Do you think there's any market drivers, like in terms of the competitiveness,
Yeah, I mean, if you look at this Congress or the administration right now, just trying to lower the cost of drugs, any lever that you pull affects an entire industry in the United States. And I think when you look at the decisions that are made on a federal level, there are lots of special interest groups involved in securing that something doesn't change for them. And so I think that contributes to the higher cost of drugs. I think it contributes to the way our health system works now and its inability to change on a dime because there are so many special interest groups involved.
That's right.
There's there's yet to be an incentive for healthcare providers to save costs.
Well, and that's one of the biggest problems that
One
we'll
of the
probably
biggest
talk about is
problems,
value-based
our
care.
payment system has rewarded volume over value, and we're trying to move towards the value end of the spectrum a little bit more. But the current analysis is that what we've got in place in terms of value-based payment experiments, models, ACOs, capitation is a big deal in our Medicaid programs and getting bigger in the Medicare program as well. It's still not enough, obviously, because our healthcare costs continue to rise faster than the costs everywhere else in the economy.
Are you familiar with value-based care? It's basically, okay, I'm just making sure.
So what is your sense? What do you think is driving that? Could drive that? Okay.
The other thing is that these other economies, healthcare economies, the ones that have been able to, that are comparable in terms of their wealth to the United States and their developed healthcare systems. I think there's, the U.S. healthcare system is 40% more costly than the next closest country, is Switzerland or something. But for most other advanced countries in the world with the big healthcare systems, they're 4 or 5% of GNP, and we're closer to 15% of GNP in our healthcare industry. Why? All of those systems have some kind of macro control on cost. They have some kind of way of either where there's the government or a public-private collaboration says prices can only rise so much, or the total spending can only rise so much in a given time. And if it looks like it's not going to, that it's going to go over that limit, we have no such limit in the United States, not yet, anyway. Because these programs, Medicare, Medicaid, and CHIP, they are entitlement programs. The total amount of spending is not controlled by policymakers. It is controlled by the increase in healthcare costs every year and the number of people that qualify.
Because it seems like an obvious solution that if you could just put something in place that reduces those costs to what is still like profitable for like the suppliers, so like the pharmaceutical companies or whoever, then you could provide coverage to a much larger group of people.
If you could get pharmaceuticals to lower their prices and doctors to lower their incomes and hospitals to lower, yes, absolutely, yes. Question is how, and to do it in a legal and fair and capitalistic way that's consistent with, like we say with this survey, people want Medicare for all, but you ask them, do you really want to get rid of the entire private health insurance industry with 5,000 companies and employing hundreds of thousands of people? No, I don't want to do that.
Do you think that's a driver, like preserving the jobs at the private health insurance?
Yeah,
Sorry. Do you think that's a driver, like preserving the jobs at the private health insurance companies?
absolutely. It's a political driver.
I would say a lot of this does depend on just the politics of the entire discussion, right?
Yeah.
And just watching President Obama go through the ACA and how many concessions he had to make. It started off at a very different program than it ended up. And same thing if you look at Texas and Medicaid expansion, each state had their own sort of political battles. But I think the political battles within Texas really do dictate, or I'm sorry, within the United States really do dictate what the outcomes are. And so it's figuring out if Americans, it seems very clear that Americans want the price of drugs to be lowered. But actually watching that sausage being made has been a very interesting thing over the past year and a half. And that's from a Republican president to try to do this. And so special interest groups are very powerful in these situations.
It's true.
I wanted to follow up on the cost control measures. So obviously the three groups that we've spoken with here are entitlement programs. As you mentioned, government can't necessarily control access to those once they're given.
Right. FQHCs, I should say, make clear, FQHCs is not an entitlement program. The government appropriates a certain amount of money that goes to FQHCs, and they have to live within their budget.
So that's capped.
That's capped.
But I guess what I'm interested in is why don't we have an ability to recalculate that incremental cost algorithm that you spoke to earlier? Why Medicare sets the bar. Medicare rates set the bar for the rest of the industry. So why don't they just freeze rates, for example? Why? They can't control who turns 65 and who gets eligible. It's an entitlement program, third rail, got it. They can control what they pay. So why not do that?
So you're saying freeze the rates for providers and for the purchasing of drugs?
Inflation. It's all politics.
Politics?
Well, everything is politics.
No, I mean,
these are all politically driven programs. These are policies in our system, our democratic
So you've
system.
spoken to the special interest groups, but if you think you had a poll of the nation that said, should Medicare and Medicaid be able to negotiate rates, freeze rates, as they see fit, as any other payer has the ability to,
Right.
Yeah.
you don't think the public would approve?
Well, we need to run the poll first. Yeah, but that's a good
They do.
point.
The majority of the public approves
Approve,
of the government negotiating with the pharmaceutical industry for
They
lower
do,
drug prices.
yes, they
Well,
in the
beyond,
polls.
beyond just drugs,
Yeah.
right?
Yeah.
Let's not just throw everything on to
With
pharmaceutical
providers as
companies.
well. I mean, I would say they release a physician fee schedule and a HOPS schedule, so every single year, and you have the ability to comment, and you have the ability to get 50 or 127 members of Congress to oppose a certain cut of a fee schedule. I mean, they do cut fee schedules every year depending on, if you haven't been cut in 10 years or if you've been raised in 10 years. So that's an ongoing negotiation every single year. And a lot of times what happens, I was in cancer care, and when we would have dramatic cuts to our laboratory services, we would get lots of members of Congress to push back on those cuts, because then we wouldn't be able to offer those services. So I think that's what your legislative body is hearing a lot of times, is when they do a cut, it sometimes rations care in some ways. And so, but there's always a negotiation and a readjustment every year of the fee schedules.
Well, at the end of the day, we want some discretion over the care provided, right?
Mm-hmm.
Private payers are doing it. I don't know my Medicare pieces and components well enough, but it sounds as though there is a copay component to D.
Mm-hmm.
You're saying B would be labs and procedures.
Mm-hmm.
And physician services.
So I don't know if we have this data, but when you look at the growth of Medicare expenses, because per my numbers, they had a much smaller population than Medicaid, but much higher spend. Obviously,
it's
that's an
elderly
older population,
population.
right?
It's an older
But,
population.
the growth of spend within Medicare, which is what we should be looking at moving forward with an aging population, where's the low-hanging fruit? Is it capping or freezing reimbursement on procedures, for example?
Well, I will say a lot of talk is about step therapy or prior authorization of certain treatments. So, for instance, I always revert to cancer because it is the most expensive disease in the United States, and the drugs are the most expensive. So does that patient that walks into a provider's office need to be on the $30,000 a month drug, or do you try them out on a cheaper drug that may have the same sort of outcomes? And so that's really the discussion that's going on. I will say in cancer, schizophrenia, HIV, all of those are considered protected classes right now because you want to get patients into the best care possible as soon as possible. But there are some movements to put some cost-saving measures in place, and that's part of the president's blueprint on lowering the price of drugs. So all of this is 100% being discussed. It's just what ends up becoming law is a slow process. And just like the move to value-based care has been incredibly slow. I think this has been going on, this conversation's been going on for probably 15 years, and we've taken baby steps to get to value-based care. Sorry. Keep going.
Yes, sir.
In one of the Balanced Budget Acts, there was an automatic cutback on physician fees every year if the cost exceeded amount and there wasn't money there. And every year there was a special legislation that was passed by Congress to stop that from happening. So Congress had passed a law signed by the president to reduce physician fees in the event that was happening. And every year it got to that cliff. Every year they turned around and they passed legislation to make sure that cut didn't occur. That being said, the consequence of cutting those fees, according to the professional physician societies, was, because those programs are voluntary for physicians to be in,
Exactly.
is the loss of physicians.
Right.
If you look at and there's no better case of that than try to find enough physicians in the state's Medicaid program
Exactly.
to adequately provide service for the millions of Texans that don't have access to health care because they don't have the financing and the funding. So that's been a great example of what happens. So when you press on that curve, if it's not mandatory for physicians to be part of the program, you're going to see a drop in that piece. Now, it doesn't mean it's right or wrong, but I'm just saying this has been the consequences of those different actions.
Agreed. And I would just say, looking at capping Medicaid rates are already very low for providers. In fact, independent providers generally try, I would venture to guess that a lot of independent providers try to mitigate their payer mix because you're paid so poorly by Medicaid. So it's not like those programs need to be cut even further. They're already fairly slim at that point.
/ comment, which is having done some different research in different venues, and I know that pharmaceutical companies do get a terrible rep, and largely it's very often deserved. But the other issue is I think we should look at the cost of getting a drug FDA approved in this country versus some of the European, Australian countries and populations, as well as maintaining an FDA approval once it's obtained. And that's something we don't talk about. The other thing is how much which pharmaceutical companies are putting their money back into research and development. Because a lot of the progress that we do actually have in medical care has come because of work that some of the pharmaceutical companies have done.
Agreed.
So before there's an impression left that, doctors make too much money and pharmaceutical companies are bad, I think we really need to realize that there are many moving parts. I've been the Medicaid darling of the disabled population for quite some time now, and I can't find people to help me take care of the patients I've served.
Right. I hope I didn't leave that impression, because
I would just tack onto that. I know Medicaid is the worst reimbursement rates, and as you mentioned, doctors are currently able to control who they see, who they don't see, who they accept. We touched on this last week, and from one man's perspective, people respond to incentives. You spend all of this money as a physician or a medical student to get there. They're looking to capitalize on it. Nature of that is getting high reimbursable patients. So, it's a pie in the, or an, idea in the sky, but I would be interested to see if there are ideas that integrate medical educational fees for Medicare, Medicaid coverage and services to sort of balance those two out. Because, as you mentioned, you continue to cut Medicare, Medicaid rates, no one's going to serve them. But you can't blame a physician when they're hundreds of thousands of dollars in debt and then ask them, do you want to serve private pay or Medicaid patients?
And also, there's not a lot of students going into family practice for that reason, and they're specializing because there's more funds in the specialty area versus family practice, ergo the development of family nurse practitioner roles in family practice.
Okay, thank you all. Ms. Lindsay, do you want to talk about your target population?
Sure. I mean, do you want me to, does everybody in here know what an Fqhc is, kind of what the requirements are? Should I go ahead and explain? Or?
Yes,
okay.
Go ahead.
So, because I didn't know, I was honestly in the healthcare industry for 2.5 years and kind of didn't know this middle lane of what an Fqhc is. So you have independent physicians, then you have hospitals, right? And then you have this thing called a federally qualified health center in the middle. And federally qualified health centers are centers that offer to anyone that walks in their door, regardless of their ability to pay, first and foremost, the primary care, but they also do a lot of add-on services. So first in your scope is primary care, and then you do vision, dental, behavioral health is a huge one because that's such a difficult thing to find for a lower income population. OBGYNs, we treat a ton of children. And then a couple other things, like we'll do nutrition, and we are doing a large study on social determinants of health right now. So Fqhcs are, you wouldn't really know when you walk into one. They don't say Fqhc on it. Ours says Legacy Community Health. But they have a couple of defining characteristics by the federal government. So one of the things that they have to do is you have to have a board that's made up of 51% or a majority of what's called consumers, so patients. So the actual board of directors is your patient population, the majority is your patient population. And the idea behind that is that they can see what's best for the underserved communities. The second thing is that Fqhcs are nonprofits, and that you often, all the money that's made is really circulated back into the development of programs to increase access to care. They must serve, the third thing is they must serve a designated, what's called underserved area. So that's designated by the federal government. So they have to be, you have to apply to the federal government and you have to be granted that you are able to serve that underserved area. And then, like I said, they must treat anyone that walks through their door, regardless of if they have insurance or not. And then we treat them on what's called a sliding scale. So a sliding scale means, if you walk in and you only make, $10,000 a year, you're most likely going to only pay about $10 or $20 for a visit, regardless of what happens in that visit. So that's a great thing that we're able to do. So I'll tell you a little bit about Legacy Community Health, just because that's where I work and that's what I do. As I said, we're the largest federally qualified health center in the state. We have 34 facilities. We're pretty much based in Houston, but we have 2 facilities out in Beaumont, one in Deer Park and one in Baytown. So we cover a very wide sort of area. What's unique about Legacy is that 20 of our facilities are actually co-located in schools, and that's a super exciting thing that I love to talk about, because seeing school-based care is a really neat thing. We have full-service primary care, labs, everything within the school, and then we offer behavioral health in the school. So seeing kids and their parents not have to take off work to get care has been something that Legacy finds very rewarding. We have about 1,000 employees, and we serve about 170,000 patients within our facility at about 520,000 appointments a year. So lots of kids coming in multiple times, same thing with OBGYN. 54% of our population is Hispanic, 23% is African American, and 14% is Caucasian. 34% of our patient population is under 12, so we're doing a lot of that CHIP and Medicaid population. And then 34% is about 20 to 44, so also adults that probably are having trouble finding insurance. We treat about 55% of our payer mix is Medicaid, and then 26% is that sliding scale, sort of uninsured population. And then we do take private insurance. Most insurances love us. And so about 15% of our patient population is private insurance. And then we only treat 4% of Medicare. So we are hoping to do some more geriatrics in the future. We find this sort of one-stop shop approach really helpful for patient populations. And then I'll just tell you the way that we're funded, because I think I was asked to cover this, is, as he mentioned, there's $5.1 billion for the Community Health Center Fund. Legacy we don't receive a ton of money from that. We are primarily funded through our reimbursements for fee-for-service through Medicare, and then also Medicaid. And what Legacy receives as an Fqhc, when you're designated, you're eligible for what's called an enhanced PPS rate. And much like a hospital or teaching hospital, they receive a slightly higher rate to take on that burden of uncompensated care of 26% of your patient population. So it's a way that the state and the federal government sort of make it able for you to treat populations in a lot of uncompensated care. We also spend a lot of time fundraising for our buildings. That's generally how we build our buildings, is through fundraising efforts. I think lots of corporations and lots of community members that have been served by Legacy find it important to give back to their community, and so that's how we sort of build our buildings. And then we receive a lot of different grants from the federal government. We're one of the largest Ryan White clinics, so we have a very large HIV population that we treat, as well as tons of different grants from HRSA and SAMHSA as well. So that's a brief overview. Yeah.
You used the terminology, the PP.
Prospective.
PPS rate. What does it stand for?
I literally knew you were going to ask this, and I wrote it down because I was like, what does PPS stand for? It's a prospective payment system.
Okay.
And then HRSA, because I use these terms constantly, never remember what they actually mean. HRSA is the Health Resources and Services Administration.
Great.
Just FYI. Yes.
Could you help me understand these patients who fall under the sliding window? Can you describe the typical patient? Why aren't they already on Medicare? Is it because they're homeless or mentally ill? And second question, I heard being based in UK and from elsewhere in Europe that often the most outrageous bills are given to people who do not have health insurance because the private payers, the insurance companies negotiate huge discounts compared to what is billed.
Oh, yeah, absolutely.
Can you give an example how that works in your setting?
Sure. And I'll tell you one more issue that's really important to FQHCs. But so how does it work from like coming in as an uninsured patient population, and who is that?
Who is an example?
Such a good question, because to be honest, I'm just learning how limited truly our state Medicaid population coverage really is. If you are which you're a man and you are, I don't know how old you are, but you would not qualify for Texas Medicaid no matter how poor you really were. So a lot of who we're seeing is individuals who are male or female younger women that don't have children. They're not eligible for any state Medicaid program. So that's
no matter how poor.
No matter how poor. If you have no income, and I can't say that for sure. The Medicaid website is very. You have to call and submit an application in order to get an answer. But I will tell you, we rarely see a male that's healthy that has Texas Medicaid. In fact, it's very clear on their website sort of who they cover. And healthy males and healthy females are not really part of that patient population. So that's really who you're seeing in that 34% that are 20 to 44. And if you're not disabled, if you don't have several different, if you're just an average healthy person, that's the people that we're seeing on a sliding scale. Maybe you're a waiter that you only make so much money, that in your restaurant doesn't provide you insurance, but your insurance is, $500 a month. You're not going to be able to afford that. So that's generally who we see on a sliding scale. And then I forgot which was
The
second
which
question.
was about the bills that the uninsured people are often given. They high
Sure,
bills.
surprise bills. So surprise bills, I will say, you wouldn't receive one of those from Legacy. We charge one rate, and so we always talk to the patient before. So we would treat you on a sliding scale, which means you would know how much you were responsible before you ever received that. Balance bills are generally when you go into an emergency room or a hospital setting, and the example most people use is that you're getting a surgery, but your anesthesiologist is actually out of network within that hospital system, and you weren't aware that anesthesiologist was out of network. So your insurance company is saying you now owe $10,000, and so you had no idea. You went to a place that you were in network, and that suddenly became a huge surprise to you. Right. So there is some movement at the state level to really rein in balance billing. It's been the talk of a lot of states across the United States. And the way that they're managing it now is that if you were to receive one of those surprise bills, Texas has a very unique system. It just launched this year, that if you call the Texas Department of Insurance and they actually mediate that price differential, the provider and the insurance company get in a phone conversation and they get into mediation and they sort out what you would be responsible for. And so that has been shown to have really reduced that rate. But I think there's been so much speculation and publicity around surprise billing that most providers are fairly afraid to do something like that at this point because there is so much.
Lindsay, could I ask on the specialty care issue, as a comprehensive primary care, when you get patients that have limited resources, no coverage, and they're found to have a cancer or some kind of chronic disease, where are you able to get them the care that they need?
You know,
and how?
Yeah, exactly. Well, who's really filled that gap is Harris Health.
Harris Health.
Harris Health has their cancer specialty, and they know that too. Most FQHCs do not provide cancer care. You can provide whatever you want, but we generally go to the hospital district to refer those patients.
Lindsay, just to, I don't need this. My question for you about the FQHC, so there's, I think, what, 6,000 plus in the United States, and you have one of the larger ones. And what I've come to understand is that some lack some critical information systems, and you just gave an example of kind of connecting with Harris Health and the community. You know, for the, is there an opportunity for FQHCs to come together on kind of unifying either buying power or, you know, kind of standards and systems so that they can tie into some of the other local health systems that they're going to partner with from just an information perspective? I mean, has there been any kind of, like, how does the organization look at a, you know, at a federal level to drive things like that?
Well, I actually think one of the challenges that we'll talk about is moving towards value-based care, and we have to have some sort of partnership on the specialty spectrum in the future. So yes, I think that's very much a part of what should happen with FQHCs. I think what you're seeing on a federal level, though, is our EHRs don't all communicate with each other. It's the most ridiculous thing, actually. Interoperability has got to be where we move so that a patient in Harris Health we can sort of see the same basic information that they've been there to, you know, and so creating interoperability not only in the electronic space but also in sort of a system of care would be probably where we're moving in the future. And I forgot, we have actually a CEO from Access Health here who's at FQHC in the Fort Bend area. And so he could do any of these, he could also answer any of these questions. So if you have anything to add, you just do that.
Or add a channel in the...
Exactly. You want to go up here?
Yes.
Sorry.
Go ahead.
About 6 years ago, there was a study done in Houston, and the idea to try to combine in some way back operations or other of the various federally qualified health centers, and it didn't move forward. So that was one of the things. And actually, originally when the FQs started here, they all started with the same, each one had a separate, but they had the same architecture for their patient records. But then they moved away from that onto separate records as they were able to, different ones were able to find different grants.
Right.
And so the different grants ended up moving towards different things. And so they moved away in many different ways from that. So there's great opportunities there, but because all of them have their own community boards, because they all have their own separate missions, the idea of trying to combine and integrate all that is a very, very difficult thing to do.
Yeah, I agree.
I work for Harris Health Systems, and then there's the Healthcare for the Homeless Houston. We are integrated, like we can see what they've done for the patient, so it kind of prevents duplication of care and minimizes what we do for the next patient, or sometimes the patients go to both. They'll come to us for certain things and go to them for certain things, but at least we can see what's being done, so that greatly helps. So we are connected in that sense.
Who are you integrated with?
With Healthcare for the Homeless Houston.
Oh, got it. Okay, got it.
Which is another.
Okay.
Can you go ahead and talk to us about the population?
Okay, I'm a family nurse practitioner. I work for Healthcare for the Homeless Harris Health Systems. So our patients, we are located in like the Salvation Army, Star of Hope, Open Door Missions. We're mostly located in the shelters. We have 9 shelters that we are at, 4 are open access clinics, 2 are family shelters, 3 men's shelters. We also have a mobile medical unit that goes out, and we have a mobile dental unit that works with us. The open access shelter, one of the clinics, we have procedure clinics, so minor procedures that patients have been walking around with a huge lipoma on their back or wherever, and they need that excised, we can send them to our procedure clinic, one of our doctors. He does procedures for us. We treat all age groups. Most of our patients are African Americans and Hispanic patients, males and females. We treat from infants to elderly. Most of the clinics are nurse practitioners, are run by nurse practitioners. We have 2 MDs. We have 3 psychiatrists. We have dentists, social workers, health educators. We have a behavioral therapist, and she's wonderful for our patients. Let me see. And our funding, we're a federally qualified health center, and our funding comes from HRSA, and we're accountable to them. We have, our patients, I think, are an advantage because since we are with the Harris Health Systems, things that we cannot handle in our clinics, we refer them to, whether it be physical therapy, surgery, labs. We do some labs, but we have access to all of our Harris Health clinics. We can send our patients as long as they have a gold card. And our patients, they're on that zero plan mostly, unless they have, other sources of income or something. And then they might pay a minimal payment. We see about 14,000 patients or so per year. We screen, like preventative health is very much emphasized. We do HIV screenings, PAP, cervical cancer screenings, breast cancer screenings, colon cancer screenings, immunizations, physical exams, education. We treat all sorts of diseases, chronic diseases, hypertension, diabetes, simple URIs, skin problems. There's a lot of scabies and stuff going on. So pain management, wound care, STDs, mental health. We have clinical indicators that we have to meet. And some of those are colon cancer screenings and cervical cancer, BMI. We address obesity, childhood BMI, childhood immunizations, adult immunizations. We do PHQ-9s, mental health screenings for our patients, prenatal care, tobacco cessation. So we do pretty much the whole family practice spectrum. One of the things that are challenges with our patients is that even though all these screenings are available, it's hard because they're transients. Some of them stay at shelters for 6 months, 3 months to 6 months to a year, and if they stay there, then they can get the care that they need. But a lot of times they go from one shelter to the next or to the streets, and it's kind of hard. So if they leave my shelter that I work at and they go out and they're on the streets, sometimes our mobile health medical can see them. So we can see where, since all of our medical records are connected, we can see, hey, he was seen on in outreach, and then we can continue care that way. And there's a lot of stuff, but it's hard to encourage the patients to do the preventative health screening because they're worried about where they're going to stay, or where they're going to eat and what are they going to eat and all that. So that we're trying to encourage preventative health to the best that we can. And sometimes many patients take heed of what we ask them to do, and trying to teach them, high blood pressure control is very important. Or there are patients that I will see for 6 months at my shelter, and then they'll come back 2 years later, and I will ask them, when was the last time you took your blood pressure? Well, 2 years ago when you gave it to me. So understanding, a lot of it is due to mental health, and the mental health sometimes causes the drug abuse. A lot of our patients have drug problems. So the drug abuse relates to the mental health and vice versa. So, but we're working along with the patients, and I think we're making a lot of headways with our patients, and we're treating them, and the connection with Harris Health is just such a marvelous thing,
I had a quick question for you. Thank you so much, because are you still going? Sorry.
No,
Okay.
I'm
Yeah, so you mentioned the challenge around the coexisting conditions, substance use disorder, and having other mental health issues. What do you do in those situations? Are you using Harris's infrastructure? Are you kind of triaging within your clinics? how do you help people that are showing up with those conditions?
In our shelters, it's a clinic. It's a mini clinic. We have over-the-counter medications, which, you know, they don't have the money to go buy their Aleve or Tylenol over the counter or cough medicine. We have that in our cabinet, so we're able to give those to them. We also have Class D pharmacy where we have prescription medications. We have a few psych meds, hypertensive meds. We have insulin. We try to take care of everything that we can take care of in the clinic. Now there's, if they need more mental health care, we have a therapist that comes and sees our patients. If they need to go see a psychiatrist, we can set that up. Dental, we can set that up. We have our dental van, we communicate very well with them, so if they have extreme tooth pain, you know, I'm able to put them on antibiotics, and then I send them to the dental, like emergency dental, and as you know, and they will extract the tooth or take care of. And we can do routine dental through all of our other dental clinics at our Harris Health.
Do you ever refer folks to the local mental health authority? Just out of curiosity, Harris Center? Okay.
No.
The local mental health authority? The Harris Center?
I don't
Just
know
curious.
if our outreach team does that, but for
They
us,
handle
we
the
have our
more
secretary.
complex
Yeah.
psychiatric cases generally,
But if they become actively suicidal or whatever, you know, we'd send them to our crisis unit at Benton.
One more question, do you do an SBIRT screen as well, or SBIRT? It's for
No.
alcohol, obviously.
No, we do the PHQ-9 screening questionnaire for depression and then go from there.
Okay, thank you.
Thank you, guys. I think our time is almost up. I just want to emphasize the importance of school-based health clinics, because a lot of the children, their first entrance into the healthcare system is through the school. So we need a lot of school-based clinics, and I'm hoping that with more discussion, we would decide to give your legacy, for example, to build, use taxpayers' money to build clinics that would serve that would serve our population, instead of using that money, the taxpayers' money, building what, stadiums for rich football teams. And I'm not trying to step on anybody's toes, but we all know what I'm talking about. We spend so many millions building stadiums for people who have the money to do it, instead of investing in clinics and other social programs that would promote health.
If it makes you feel any better, the idea around school-based health clinics and just school-based mental health services at the state legislature is an emergency item that the governor has declared. We have several bills from Legacy that are in the works to help incentivize other providers to get into the space. I think you're going to see a lot of state funds dedicated to behavioral health in schools.
That would be fantastic. Dr. Begley, you have any closing comments?
I just think this, you know, that my closing message would be that this safety net system is large. We didn't really get to the local level, the hospital district, the Harris Health, although Saramma mentioned it, and the county and the hospital uncompensated care, charity care, indigent care programs. This is another multi-billion, not as big as. But these other ones, I just think it's, you know, Medicare, so many programs, Medicare, Medicaid, CHIP, Fqhcs, then you have your local hospital system, indigent care programs, and your county public hospital systems. All of that, all right, is our safety net system. And so there are resources out there for these vulnerable populations. All right, and we just, but they're complicated, they're patchwork. They've been created over the last 50 or 60 years, and they have different eligibility rules and funding sources and standards of care and best practices. So it's really a challenge to do the integration that we need. and to get the payment mechanism lined up to reward integration and coordinated care and cost-efficient care and lack of duplication. So, part of our generosity in creating all these programs for vulnerable populations has created the problem of fragmentation. And not being able to provide all the services that are needed in an appropriate manner in a cost-efficient way. So there's a lot of work to be done, but it's a great field to work in.
Okay. Any recommendations from you, the audience, in terms of resolving some of these challenges you've heard today? Yes, ma'am.
This is not recommendations, but just some observations, and I think people have observed that there are other populations that don't fall into the safety net program. For example, you mentioned that the young female and male people who are in that age, and often that those companies that they work for, they don't provide health benefit, no health insurance.
Yes.
Right.
So I don't know. I think we need safety net program for everyone, but at some basic level, I just feel like there's some group of population that don't get help.
I would just say that that's exactly the sort of patient population that we're seeing in the Fqhcs, right? Is the completely uninsured population. So I think we do serve as a safety net for that primary care for those
Except for
individuals.
healthy men like him, right?
Well, no, that's what we do. I mean, we treat them on a sliding scale.
You do, okay.
And then the Harris Health System, our local public hospital system,
Same thing.
is largely adult
Exactly.
men and women that don't qualify for Medicaid, Medicare. It might be because of their immigration status, but it's also because these programs don't cover that population. But we do have Harris Health for that.
Right, and we have tons of uncompensated care, and that's exactly that's part of a requirement is treating whoever walks through our door. So
yeah.
That's where most people go is Harris Health or over here to Legacy.
These informations are not very easily accessible, or people may not know about it. I personally have an experience with that, and in Harris Health, for example, the Go Card. Well, that application to the Go Card is not that it takes long time, and the process is not that straightforward. Anyway, that's just what I have observed.
Agree.
So what we've seen for uninsured populations that are not covered by any of these things, that they're relying on local health providers through laws like EMTALA, which says that you can't turn somebody away regardless of ability to pay if they present themselves in an emergency room. The Texas law that says X% of your revenues for nonprofit hospitals have to go towards community-based programs. And then the number that I've never seen, but I would really like to know is, and maybe Chuck, you've seen this, how much do our community-based physicians care do they provide in their offices or in their clinics that are non-reimbursed that they write off for these patients? Does anybody have a sense of the size of that number so we can really get a sense on how we're financing the healthcare system on the backs of these providers?
That's a great question, especially because we don't, as an Fqhc, we have some confusion as to whether or not we can provide telemedicine services, and so I would venture to guess that a lot of after-hours care is done because we can't be reimbursed for it at this point. So, yeah. But Chuck, is there anything that would indicate?
No, I
The,
don't
the
know.
closest thing to it is that we have in the way of an existing data system is an annual survey that the Texas Medical Association does of practicing physicians in the state, and they have a question on that. But it's not reliable information. The sample that responds to it is a distorted sample of physicians, so nobody's ever thought that it's never generated a number that we've ever used in much work that gets done in the area. But I would venture to say that it's a relatively small figure as compared to this stuff that we're talking about tonight. It just, yeah, it's there. It's significant for some physicians, but overall, in terms of serving a significant percentage of meeting the need of a significant percentage of the safety net population, and being a part of our significant cost of of the safety net, no.
Okay, every good thing must come to an end. I'm sorry to say our time is up, and I thank all of you for this enlightening discussion we had today. Thank you. A hand for the